Welcome all, and welcome to the 11th edition of the CCD Rounds. We'll have a very exciting webinar today. My name is Bo Vesli. I'm from the Global Cities Changing Diabetes Program team. And I'm stepping in for our normal presenter, Niels Lund, who's unable to be here today. And sometimes we do like others do. We are two people replacing him. I'm joined here by Hans Uldal Poulsen. Please, Hans, say a few words about yourself.
Yes, thank you, Bo. So I'm Hans Uldal. I'm part of the Diabetes Prevention Investment Lab here in Denmark. It's a professional network of actors working on accelerating investments in prevention and care, and then a senior advisor to the Dalberg group. So I'll be facilitating a panel discussion later on today.
Yes. Thank you, Hans. And for those of you who may not know Cities Changing Diabetes, we are a program partnering with cities to improve health, especially for the vulnerable population. And we started in 2014, and we have since grown to more than 40 partner cities. And we have a very exciting theme today. It's one of those topics where we are really trying very hard to unlock additional resources for the cause that we are trying to drive forward. Today we have quite a busy speaker list because we are trying to do so much in 1 hour. We are starting with Kirsa Buch Christensen, a senior advisor at World Diabetes Foundation. We have Chintan Maru, who's the CEO and founder of Leapfrog to Value. We have Peter Bindslev Iversen. He's the head of the Diabetes Prevention Investment Lab in Denmark. We have Lars Eibeholm, who's a head of sustainable banking at SEB. Hello, Lars. And finally, we have Lucia Santirso Richards, who's the investment director at Outcomes Partnerships. So that's quite a formidable list of participants and speakers here. And as Hans said, he will try to moderate a productive discussion with everyone throughout. At this first step, we will have Kirsa and Chintan to kick off for around 15 minutes. And Kirsa and Chintan will take an angle here that's quite interesting, talking especially about the need to unlock this type of financing, innovative financing for prevention in low resource settings. And of course, you can argue that any innovation that you do in low resource settings, you can take back and use in higher resource setting as well. So it's super relevant for all of us who are in this conversation. I think that part of my role here is to make sure that we get through the whole program. So Kirsa and Chintan, don't be worried if I become a little bit sort of a timekeeper type of person during our session here. So Kirsa, will you please start off by introducing how the World Diabetes Foundation views this theme and why you think it's relevant and important?
Thank you, Bo, and thank you, Hans. I'm just sharing my presentation. Can you see the presentation?
Yes, excellent.
So thank you to the CCD team for inviting the World Diabetes Foundation to join you at this webinar on innovative financing. At WDF, we are focused on tackling diabetes and other non-communicable diseases in LMICs. And that is why we want to use this opportunity to make the case for deploying innovative financing models in low resource settings. At a global level, it's estimated that 530 million adults have diabetes, and this will actually grow to 780 million adults having diabetes in 20 years' time. This is a huge burden on health systems worldwide. It's estimated that 75% of people living with diabetes live in low and middle income countries. That amounts to more than 400 million people living with diabetes in countries with limited financial and human resources. In the past decade, we have witnessed how this burden of disease have changed. NCDs, including diabetes as one of the major NCDs, have become the leading cause of death worldwide. I think we all, or our governments also tend to accept these deaths from NCDs as unavoidable, but they are not really. Most of them, or a lot of them, are actually preventable. It's estimated that 67% of people with type 2 diabetes in low-income countries are undiagnosed. This is really disturbing, as we know that untreated diabetes is associated with serious complications such as blindness, amputations, cardiovascular diseases, kidney disease, depression, and even premature death. In WDF, we therefore see it as an obligation to support low and middle income countries in addressing diabetes and other NCDs. Health systems in LMICs are often not geared towards addressing NCDs. They struggle with the double burden of disease. They struggle with competing priorities, with inequality in the access to healthcare, and with poverty in general. There's still low international support for tackling NCDs, even though this burden of disease carry a huge cost, both in terms of the high treatment cost, imposing a direct economic burden on health systems, on households, but also as a society as a whole. Also, when we consider the indirect cost in terms of lost productivity from NCD-related disabilities and premature deaths. Over the past 20 years, WDF has supported a broad range of initiatives that have made a tangible difference to millions of people in LMICs. Some of our output-based results are listed here in terms of the patients treated, people screened, healthcare workers trained, and also clinics established or strengthened with diabetes care through our project partnerships. We have supported through our projects the development of new models like mobile clinics using trained nurses and telemedicine as a way to address the lack of specialists. We have supported the piloting of interventions and new approaches such as community-led peer-to-peer support, continuous in-service training and supportive supervision of healthcare workers, and the empowerment of patients. With increased support from our donors, we have also been able to significantly increase our efforts in a number of countries, in particular in East Africa with Tanzania and Kenya, but also in Jordan and Lebanon. I think it's safe to say that we have become a trusted partner to ministries of health in many countries. We are a partner to regional organizations such as UNRWA, and we are also partnering with global organizations such as WHO and UNHCR. Yet, we can also see that grants from philanthropic organizations or other development partners are not enough. Only 1 to 2% of the global health financing is dedicated to NCDs and LMICs. This is insufficient to address the burden of disease and also to attain the global targets as we have agreed and spelled out in the SDG 3 and also in the WHO Global Action Plan on NCDs. So we find that it's time to scale up some of our most successful interventions where we could significantly increase our impact if we had the adequate financing models. To address this financing gap, we want to explore and implement and scale up innovative financing solutions such as social impact bonds and other outcome-based models. We want to do this in WDF through engaging with our partners and also to find new types of partners, building more evidence around these instruments, co-development investment cases, and also actually deploy and test these innovative financing models. So we want to supplement our existing grant models with innovative financing models. We don't want to completely go away from providing grants because it's still needed, but we also need to find new ways to unlock additional funding resources from both public and private sector players, while ensuring that these resources are allocated to the most impactful projects. The models needs to be based on an investment logic which increases efficiency and accountability as we start focusing more on outcomes and value creation and not just activities and outputs. By accelerating the implementation of the most effective solutions, the models will hopefully also stimulate social innovation by bringing more operational agility to the interventions. So with this, I hope I've made the case that it's urgently needed to accelerate the scaling of effective solutions to match the challenges associated with prevention and treatment of diabetes in low-income countries, but also that innovative financing models could represent a valuable addition to our existing grant-based work. So thank you a lot for the attention, and back to you, Hans and Bo.
Thanks a lot, Kirsa. You made such a good case. You have so much experience now about what works in different settings. And it's very interesting how you have an idea that this can be turned into a bigger scale investable solutions. That's resources can be unlocked there. It's fascinating. And this thing about making them into sort of investment models or investment projects, it sharpens, of course, the focus on, getting the most impactful activities funded. So that's fascinating. And I guess that plays really well to your view of the world, Chintan Maru, CEO and founder of Leapfrog to Value. So I sense that there's a very natural extension here in what you're about to say.
We're a platform that's advancing value-based care in India, South Africa, Ghana, and beyond. And the conundrum at the center of our work is an observation that buying more healthcare doesn't necessarily get you better health. And diabetes is a case in point for this observation that more healthcare doesn't equal better health. What does that mean? 3 ideas: too much, too late. In the US, a third of healthcare spending is in the last 6 months of life, and the prototypical patient is someone with late-stage diabetes. Too late because we've underinvested early on in prevention, and too much because our systems tend to churn out drugs and procedures that may be of little value at a late stage. Secondly, we prescribe more than we coach. In the rush of a typical doctor's visit, we end up looking at a lab value and treating that, writing a script, rather than looking at the whole patient. And coaching is different. It's having the time and curiosity to understand and change human behavior, which may actually prevent the need of the prescription in the first place. And then third, we sometimes end up with great care that nobody wants. Innovation that's focused on drugs or devices, but that's embedded in delivery models that aren't human-centered, that have low patient engagement and therefore mediocre outcomes. And so the implication for today's discussion, here's a makes a point for financing more. The question is, if we expand financing, do we run the risk of increasing healthcare spending without improving health? So value-based care is an alternative paradigm that really prioritizes health over healthcare. And it's grounded in this simple equation on the left, defining value, where the numerator are the outcomes that matter to patients. And for diabetes, that includes the clinical, like glycemic control, but also factors like self-efficacy in managing care, psychological well-being. Those matter too. And the denominator are the total costs of achieving those outcomes. We traditionally optimize specific budget items, staff time, cost of a drug. But when we aggregate costs across the patient journey, we see that investments in quality can have a payoff in the long run. So when we integrate this concept of value into the system of how we measure performance, how we optimize delivery, how we pay providers or allocate resources, then we can, we believe, achieve that higher value vision. And would like you to take a moment to ask yourself, how does your system measure, deliver, and pay for care today? How might it measure, deliver, and pay for value? So to make this more vivid, what does transformation look like? For the patient, it is care optimized for this broader set of human-centered outcomes, broader idea of well-being. It's really investing in coaching healthy behaviors. What does it mean for the provider? It means a single provider entity has the visibility into and accountability for generating value for patients, which is often really centered around community-based solutions. What does it mean for the payer? It means really aligning financing and payment models to this bigger vision of value. So value-based care is grounded in two hypotheses. And here's the first, that a human-centered approach can achieve better outcomes. We've historically focused on the bottom row here, access, adherence, diabetes control. You'll see the diabetes compact targets in light blue. Good health systems do track these, but even in those systems, we see big drop-offs between them. When there's good access, sometimes adherence is low, and diabetes control is even lower. And so the thesis here is, if we look at these top two bubbles, can we build a human-centered model that also improves quality of life and care experience? And the arrows in this schematic are really the hypotheses that illustrate this concept, that can a human-centered approach achieve better outcomes? How do you measure this? Our partner, International Consortium for Health Outcomes Measurement, has developed an outcome set that takes this human-centered view. Don't want to go into the details today, but consider this a resource to look at later. And it has that more sort of holistic view. And so what's the second part of the hypothesis? It's that a human-centered approach not only generates better outcomes, but could also be a better buy. So I mentioned previously, we tend to optimize around budget lines. While this is important, it can also be penny wise and pound foolish. When we stack up the costs over the long term, we may see that actually spending more on behavior change, quality of life, and care experience for diabetes ultimately has a payoff by reducing the many downstream complications of diabetes that Kirza was pointing to. And so as you consider innovative financing mechanisms, I would encourage you to try to build this business case that takes that longer term view. And then finally, I'll share briefly a case study from India that we're working on. So in India, most health insurance covers only hospital care and doesn't include outpatient care. People with diabetes can't even buy insurance because they're considered too high risk. And so if you do have diabetes, there's no coverage for that outpatient management. We worked with a private insurance company and an innovative diabetes management provider to help develop a value-based solution, a provider that has created a tech-enabled virtual diabetes reversal program focused on behavior change, highly tailored to individual experience. And at first, the price of this was considered too expensive for the Indian market. But in this value-based arrangement, this provider has agreed to put half the revenue at risk, paid only if they achieve the target on human-centered outcomes. And so the patient receives, in this case, a financial incentive if they achieve their own targets as well. And the insurance company is excited about this because it's an opportunity for them to engage patients that previously they couldn't serve, and start better managing the long-term costs of diabetes complications. And so if this is successful, it helps build a case for how you might mobilize more financing towards a human-centered approach to diabetes care in India. And overall, I'm optimistic that models like these can achieve better outcomes at a better cost, and could be a useful source of inspiration for these innovative financing models. Back to our moderators. Thank you.
Thanks so much, Chintan and Kirsa. What a scene setting. And I love, Chintan, that you end saying human-centered, while you also say investment and value, because sometimes people perceive those two as opposite. And I think in this, we are trying to make the case that it's not the opposite. It's something that's comparable. So I think we'll go to very quickly to our panel, and Hans will moderate that conversation. So over to you, Hans.
Yes. And thank you, Kirsa. Thank you, Chintan, for this great intro. And I think that you made a very good case that it's not only about that we need more resources, we also need to think about how we deploy the resources. And for that, we need new instruments, new innovative financing solution, and we need new alliances. So in order to see how that could work, we have three panelists. We have Peter Binsley, who's head of the Diabetes Prevention Investment Lab, who will tell us a bit about how can you structure a model, how can a model look like if you want to unlock new financing. Then we have Lucia Santiago-Richard, who's the investment director of Outcome Partnership, who will think about, okay, what kind of interventions could you think about if you are to create the most value? And then finally, we have Elias Eibenholm, who will say, well, show me the money. Where's the investment case? Can we unlock additional financing? So with that short introduction, I would like to welcome Peter as our first panelist here.
Thank you.
And Peter, I know that you, as part of the Diabetes Prevention Lab, have been in dialogue with multiple public authorities, service providers, investors, working on how to unlock new financing for preventing diabetes and advancing care. Diabetes impact bonds, what is that? Can you just give us a brief introduction to what that model is all about?
Yes, I think when you want to do like diabetes impact bonds, I think what is important to have like a strong partnership model. And I think like what we achieved like together with Aarhus Municipality and with you and with other partners is that actually having the municipality having like the Steno Diabetes Centers, like having the clinical experience and having people who know something about economics as well, and bringing those together on a concrete like challenge that we want to address. And for us, it was like actually to prevent like complications coming from diabetes. So, and I think what the point here was to make sure that you have like a short-term budget impact of what you do, that you actually realize that the capacity is not there at the moment, and then actually go over this silo thinking. And based on that, you can start developing a model.
So some of the discussion I know that you've been part of is, say that I'm a public authority. I face the challenge that Kirsa presented earlier today, that we have this huge burden. I want to reduce that and say, I have no money for that. Mm-hmm. What would your response be to me then?
I think that's actually what we realized when you're working with the municipalities is that like you have to say that, okay, you don't have the money, but we can actually come and bring you the money and take out the risk from you and actually de-risk the investment from you. And if you do not have, if we cannot deliver what actually was promised, then we can actually de-risk it from you, and you don't have to pay or actually to pay less. So I think that is the way to go, actually, to put in the money. And I think Lars, that is coming on later, can put more words to that. And I think like what's happening here is that like in Aarhus, we realized that we would go for like 450 patients or citizens that were like in difficult situations, in a vulnerable position, and we were developing a targeted approach to that we could document, and I think that was the way to go for this. And as I said, like we have the resources, both the financial as well as the clinical resources to show that we can actually do an investment that is actually paying off.
So maybe you can just explain it a bit more in detail for the audience. So say I have 100 patients in a municipality. I know that there's a severe risk that they will develop a diabetes-related complication. And I also, based on some of the ideas that Kirsa had shared with me, a good idea for an intervention. I know what it will take to actually move these people. Mm-hmm. So what would be the next step? How would you start up a conversation there? So I have a strong desire, I have an intervention, I have no money. Mm-hmm. What would the business model look like?
The business model will look like is that like most of the investment will be like within the health sector, whereas the most of the benefit would be like in the social sector or within the hospital sector. In the country that I know best, Denmark, there you have like you have the hospital sector where the funding is different from what you have in the health sector in general. So it's actually to show that there's an investment case for for the one that is actually doing the investment, and then show there are added benefits within the social sector and within the health sector, in the hospital sector. So I think like for like a municipality to go into this, you have to show what is in it for me. And I think that's actually what we managed to do in Aarhus. And then you bring together both the health partners within the municipality, the social partners within the municipality, as well as the hospital sector, which is different funded in our part. But actually, I think you have to show the benefit for the one partner that is doing the actual work. What's in it for me is actually what is driving this investment.
And then maybe just to add some of the perspectives from Chinchan earlier. So he was talking about value in a broader sense. So based on the dialogue you have been having, so how do you balance it, need for better patient outcomes, budget savings, Are they equally important, and are they addressed as part of the same project, or how do you deal with this multiple impact dimension?
Yeah, I think like the social outcome and the welfare and the if you measure it in qualities or whatever you want to measure it in, but I think like if you are looking at it from the municipality perspective, you want to know what is the budget impact for me, and if you're not showing that is actually value for me from my budget perspective, it's very hard to go on. And I think that is really where you have either to bring in like special funding so you can actually say, okay, you don't have everything within your budget, but then we can actually bring in as like an external resource, an external funder, showing that you can actually invest, and then you're actually trying to bring in the money from the other partners later.
Okay, thank you. I think maybe what I'll do here would be to invite you, Lucia, Sanjero, Richard, to provide a perspective on how to design an intervention that complies with the ideas that Chin-Chin just mentioned and address the need that Kirsten mentioned earlier. So could you give us a perspective of how to design an intervention and what would be most important to think of if you are to create something that should be anchored in an impact bond or an outcome-based contract? Over to you.
Yeah, of course. Of course, thank you so much. So how I like to think about designing an intervention is to use a theory of change model to do so. And so what we try to do is first we think about who is it exactly that you're trying to help and really define that target group. In our specific case, in the diabetes prevention program that we run in Devon in the UK, we were trying to help people at risk of developing diabetes type 2. So that's part one. And then you go all the way to the end and think, what is the ultimate outcome that you really want to achieve? And in this case, it was revert that risk from them becoming diabetic. And then it's about feeling what has to happen in the middle to go from one place to another. And so there's a couple of things that you need to think through. So one is, how are we going to track the progress that we're going to actually achieve that? And think about what are those leading indicators, because knowing that you've reverted diabetes might take a couple of years to find out or be able to conclude that that's the case. And so in our case, what we decided to do was to measure, are people engaging with the program? So count literally how many people are engaging and joining the program. But then secondly, what are the parameters that are clearly indicating that they may become diabetic and that are indicating that they may reduce so. And in this case, we use waist, weight, and blood sugar levels. So we measure that every 6 months to check were we being effective or not. Then the next step is to find the right intervention that will achieve those outcomes. And I guess it depends on the situation, what you're trying to solve. I think luckily for diabetes, there is quite a bit of research around interventions that work and social interventions that work. Ideally, you want to look at validated interventions, but that might not always be the case. And if that's not the case, then I would encourage you to look at interventions that can clearly demonstrate the outcomes achieved. And if you then have a range of interventions, then you should look at the total outcomes achieved and how much did it cost to deliver those interventions. And then you divide the number of total outcomes by you divide the total cost by the outcomes, and then you have a price per outcome. And you can then choose the intervention that is most effective and most cost effective. So that's the first part of it. And then the second part, which this part you can do for any type of service that you're delivering. It doesn't need to be an outcomes contract. But one thing that I really wanted to highlight is that outcomes contracts really are able to bring a flexibility that other services can't bring. And so it's really important that that is built into the intervention. And I just want to emphasize, at least in the UK, traditional services, they follow a very clear specification, and so you have to deliver that no matter what. But when you have an outcomes contract, if it's well designed, you have an outcomes that you're focusing on, and then you're constantly solving, how can I improve the service? How can I improve to achieve that outcome? And so theirs was really important to, one, create a system where you can create that change. And that speaks to the point around collaboration with all of stakeholders. It's really important that you also have continuous data to be able to kind of learn what is happening and be able to adapt that and make sure that you have enough resources to collect that data and look at the data on a regular basis. And so then hopefully you can then really continuously improve, learn from what's happening on the ground, continuously personalize the service. I think linking to what Chintan was saying before, really important to really not just take kind of data on what is happening to the weight and waist and blood sugar of these people, but how are they experiencing the intervention? How is it working out for them? Are they wanting to engage with it? And then improve that as much as possible. And lastly, I think one last point that I think is also really important is having that flexibility to disrupt. And this is about disrupting the systems. Traditionally, when we are working these interventions, one of the biggest barriers that we will face is often a systemic issue, not an issue with changing attitudes or mindsets of the people that we're supporting, not necessarily changing the way that the organization that is delivering the service is working, but actually changing the barriers around it. And so building the right partnerships and groups of stakeholders around you to support you in the delivery is also really important. Sorry, a very long answer.
That was very good. Thank you very much. And I think that you also stress some important points here. So it's not just about quantity, it's also about quality when you think about outcome-based contracts. And then I think what I hear you say is also transparency and data. It's essential if you really want to improve the quality and improve patient outcomes. What you need to do is to make sure that you can track and monitor progress. So I just have one question here as a last question in this round is, you talk about activity-based result indicators. Do people show up? Are they engaged in the program? And then also some outcome metrics. They say, how do the blood sugar level develop? What about the BMI? And if I have Peter here in the room, he was talking about show me the money. So when you're engaging with different stakeholders, are they equally interested in activity-based and outcome-based measures when you are going to present the potential impact of the intervention?
I guess it depends on the stakeholders. I think commissioners in my experience, they tend to care about ultimately, they tend to have a budget and they want to use it for the best outcomes possible, so that they will be very mindful of how many people you're supporting and what outcomes you're achieving with that person, while I guess the organizations delivering the support, they might be more involved with the things that are happening earlier in the program in terms of the inputs and indicators, so that they can use that to improve the service. But I guess what is really important is that before the service is delivered, that there is that alignment on what is important to everybody. And I think, again, focusing on the outcomes helps that, because even though you might be coming at different angles, what everybody ultimately hopefully cares about is ensuring that you're reducing that risk of diabetes in the case of my program. And so if you can agree on that and agree on this is how we're going to measure it, this is what's going to tell us that we're going to achieve it, then everybody can come with you in that journey, and not get too impatient about seeing the outcomes, but understand these are natural steps that need to happen, and this is part of the process of continuously improving the service so that we can maximize those outcomes.
So again, stressing the partnership approach here. It's more than just an investment. It's actually a partnership model that we need to get in place here. Thank you so much. Time is running a bit short, so I'll just pause you for a second. And just as a last comment, I'll say that when we presented your case to the municipalities here in Denmark, that was what unlocked the conversation for developing the first development impact bond here in Denmark. So thank you for that. And thank you for joining the call today. Our last panelist would be Lars from SEB, who will take on provide us with an investor perspective on the diabetes impact bonds model. So, is this an interesting investment, and why is that? So, Lars, could I ask you just to give share your reflection on diabetes impact bonds and why it's interesting to you as an investor?
Yeah. Thank you very much, and good afternoon to everybody. Yes, I think we talk to a lot of investors, and social investments are extremely topical. We feel the investor community really would like to engage and also to take their responsibility in many ways to society and also healthcare systems. So there's no doubt there's a huge interest. But as Kirsa also was mentioning, we need to drag them to the table, and we need to have other type of money to the table. And then we are talking about investors and typically professional investors. And the thing is, these investors typically manage other people's money. Hence, they would need to invest them and also provide with a degree of return. So, we need to move away from the grant system, but develop a sort of an investment type. Hence, the money spent actually needs to go back to the investors with a return, so to say. And this is what we need to create here. We need to create a partnership where all values are put on the table, and then somehow create a sharing model where the shared benefits or the shared savings that actually typically will show up in the healthcare system or in the life of living and all that, as Chin-Chan you also highlighted. These are the ones that needs to be brought to the table, and through a sort of a performance-linked model, we can create incentives for all parties, also the ones that actually do the interventions, but also for the savers and for the investors to come to the table with the right incentives, and then, so to say, create an investment that actually also provide a return. Because if the healthcare systems are able to see and we can document that these upfront interventions actually works and it is paid off. So they need to be willing to share a small part of their savings and bring them back to the investors together with of course the investments, and we can actually document that, and we can see that it is doable. And diabetes is a very good case, because we have a sort of a digital measure, namely the blood test, that actually can measure, is the interventions working? And by using that, we can create the performance-linked model around that, and thereby sort of say, okay, the preventions are actually working, and it's we are achieving full results here. So we also would need to share as a high amount of sharings with the investors. Hence, the investors, if the interventions are working, they will actually also get a higher return on their investments. And these are the model that we want to create. The biggest challenge here right now is actually, if we want to drag the big money to the table, these are typical the professional investors, but we are still working with new risk models, new types of investments here, which they are not used to. And there's also another sort of thing at the moment. Somehow, at the moment, the investments are small still. We know we have a global problem, but all the projects are typically local, smaller scale. And if we need to engage the big professional investors, they also need to see that, well, okay, it needs to have a sizable scale so that we can add the resources actually to start looking at this and also developing the risk and return models. Because, of course, this is a completely new risk type that they would take on board together with other risks that they take on behalf of their investors. For example, FX, commodity, equities, infrastructure, yields, etc. All these types of typical normal financial risks, they have models for. This would be a new type of models or new type of risk where they would need to somehow have a model and try to deal with it. But they really would like to be engaged. But we just need to find the right models and create the right return, the right risks, and then be able to scale it up to get them engaged.
So much for sharing that perspective. It's very good news. And the idea that, it seems also that you agree that starting with the partnership, that's the way to start, creating the right partners, bringing them to the table, and then having this idea about how can we share the value that we can create collectively. That's a key starting point. If I can just ask you one question, Lars. I know that you have been looking at different interventions, and you are leading an initiative here where you are trying to gather different municipalities, different partners in a collective process to create a program that is somewhat bigger than the program that one municipality might be interested in. Could you say a bit more about what is your idea of kind of bridging different municipalities here? Is it all about scale, or is it also other things that you're considering here?
It's about scale because we want to demonstrate that we can scale this, and then we really would like to see also private investors taking part. But yes, it is about creating the business model, and in Denmark, it's the municipalities. We need to lay out, here's the benefits. And then there's also a thing that we need to agree on, that the intervention, Lucia, as you mentioned, that needs to be standardized. We need to focus on the things that works, because it's not sort of a table where you can cherry, because it needs to be standardized so it can be scaled. And here, of course, the municipalities would need to accept that we standardize this. But then again, we can come with evidence and say, if we do this, these are the interventions. We know it works because we have evidence for that. And having that conversation with multiple municipalities, we believe that we can show them the business model, come with a standardized product of interventions. And by having that sort of outlined, we believed that we can drag the investors to the table, and through that package, sort of create the model with incentives. So there's an incentives for everybody to go ahead and invest.
Thank you so much. And it seems like if we have the right focus on standardization and alliances, that you're quite confident that we can actually mobilize the capital that we need in order to accelerate intervention that can prevent diabetes. That is very positive, and I think that we are very confident on that. So I'm just one question for you, Peter, here then. So this dialogue on trying to mobilize several municipalities at the same time. So do you see as a health authority that what is the potential in terms of sharing knowledges across cities? Are there any potential there that we should be aware of?
Yeah, I'm definitely right. And I believe that Lars is pointing in the right direction. Since the investment at the moment are very small, we have to pool them. And as part of that, you need to have like a shared like network of knowledge. And I think that a part of that is actually building, besides doing the investments, you have to build like a way to share knowledge. And I think like some kind of class or whatever, like a kind of network is the way to go about that.
Thank you. I think we are running a bit short of time, so maybe Bo, you'll come back.
Yes, so we have to do without the Q&A, and that's super painful. But there will be an occasion again in the beginning of 2023. We will have another session on social investment. We will have some concrete cases who will present what they're doing and their progress. So there will be more quite soon, we can tell you. If you want to share this session with your colleagues or you want to revisit part of it, it will be available on the Cities Changing Diabetes YouTube channel. And we also have a few resources available on the Cities Changing Diabetes website in the Take Action section. We actually have a brand new guide to getting started with social investment or diabetes impact bonds. Hans here has been very kind to help us develop that. You can reach out to us if you want to connect with some of our speakers, and I want to thank all the speakers, all the panelists for being part of this. You've been tremendous, and thank you for being so patient. This year on 15th of December, and there we will have the Healthy Childhood Challenge. The 3 winning projects will present themselves, and you can learn about what they are all about. But I just want to say thank you so much, and I thank you all. And as Niels Lund, the usual presenter here, always says, keep sharing. Thank you.